Good evening and welcome you all for this subspecialty webinar jointly organized by ISU, USI and Urolithiasis subsection. The theme of this webinar is suction in endourology. The convener for this webinar is Dr. Abhay Mahajan, who is also the chairman of Urolithiasis subsection, and I think he's the right person to talk on this subject, suction in endourology. It's my great pleasure to introduce you all to Dr. Abhay. Can you see my screen?
Yeah.
So Dr. Abhay is the Chief Urologist of Sai Urology Hospital, and he's also the Professor and Head Department of Urology at MGM Medical College. He has got many academic achievements, many publications, book chapters. He's the operating faculty at various live operative workshops. He regularly conducts the LEAP program where he teaches youngsters, residents in endourology procedures. He has honored, like he was the past secretary of Aurangabad Urology Association, many feathers in his cap. So I'll not go through all these things. Before I hand over to Dr. Abhay, I request the President of Urological Society of India, Dr. Keshavamurthy sir is here. I request sir to give his opening remarks before we start the session. Over to you, sir. Keshav sir.
Thank you, Dr. Surya Prakash, and it gives me great pleasure to welcome all of you to this webinar being conducted by the Urolithiasis section of the Urological Society of India on a topic which is very relevant, suction in endourology. And this is a very relevant topic because now you have the suction emerging as the most important adjunct for the endourological procedure, especially RIRS, and where you have to have improved visualization to achieve the complete stone clearance, because you are competing with PCNLs now. When you want to tell that there's complete stone clearance, so you are being compared with PCNLs for stone clearance, and also it gives us better intrarenal pressure. So it's fortunate that we have excellent faculty who will be deliberating on this topic, and I think it will be a thought-provoking session. I encourage all of you to participate actively. Thank you, and over to you, Dr. Suri.
Thank you, sir. We also have here Honorary Secretary of USI, Dr. Uttam Mete, sir. Dr. Uttam, sir, I request you to give your opening remarks.
Thank you, Dr. Surya. I first must congratulate you for having this webinar, and Dr. Keshavamurthy, our president, and Dr. Abhay, the convener, Dr. Vishwajeet, the secretary of the section, and of course our Dr. Surya. So and other faculty members as well as the international faculty. I can see there are 3 international faculty members: Dr. Steffi, Dr. Jia, and Dr. Takaki from Japan. All of you, we welcome on behalf of USI, and I'm sure this is going to be a good webinar, and it will be very informative. As our president has already told, that endourology has been revolutionized or evolutionized for the last 2 decades, and I think one of them is the section, and all the improvement in the technique as well as technology. The surgeons have improved themselves because of the good techniques, and the technology has come in a big way. Now, whether this technology is going to help us for better clearance and better outcome or not, the time will tell us, and whether there are some limitations also or not. And these speakers are going to elaborate on their personal experience also, which will help us for our day-to-day activity. With I must thank this Urolithiasis Society subsection as well as our Dr. Surya and all the international faculty members. Welcome to our webinar. Thank you very much.
Thank you, sir. Thank you very much for your comments. Without wasting much time, we will go on to the webinar because this Dr. Abhay has made a very jam-packed program. He has invited all the esteemed stalwarts in endourology. So this is going to be an exciting webinar. Over to you, Dr. Abhay.
Yeah. Thank you very much. Thank you, Urological Society of India, President Dr. Keshavamurthy, Secretary Dr. Uttam Mete. Thank you very much, Indian School of Urology Chairman Dr. Kumar Vaddi, Surya Prakash Vaddi. So this was the topic that we had decided in the council, which is the latest and the most innovative topic, and so we thought that we'll take up this topic for this webinar. So good evening, respected seniors, esteemed national and international faculty, and dear colleagues. So it gives me an immense pleasure as chairman of the Urolithiasis section to welcome you all for this focused academic webinar on suction in endourology. So over the last decade, endourology has undergone transformative evolution from conventional PCNL to miniaturized systems, from standard RIRS to high-power laser lithotripsy. We have consistently pushed the boundaries of what is possible. Yet, along with technological advancements, came new challenges like intrarenal pressures, infections, complications, visibility issues, and operative inefficiency. So today, suction is no longer a mere accessory. It has emerged as a strategic adjunct, influencing the stone clearance, operative time, improving the intrarenal pressure dynamics, sepsis prevention, and overall procedural safety. So whether we speak of suction-assisted access sheaths in RIRS or suction-enabled PCNL platforms, this concept is redefining how we approach stone surgery. So we have privilege to have with us distinguished international and national experts who have contributed significantly to innovation, research, and clinical refinement in this domain. Their clinical experience will help us move beyond anecdotal adoption towards evidence-based protocol-driven implementation. This webinar is not merely about devices. It is about physiology, pressure control, fluid dynamics, ergonomics, and patient safety. So I'm confident that today's academic exchange will stimulate discussion, challenge existing practices, and inspire us to integrate suction technology judiciously into our day-to-day practice. So thank you all for joining. Let us begin this enriching scientific session. And for this webinar, I invite the first speaker, Dr. Steffi Yuen from Hong Kong, and she's going to speak on intrarenal pressures in modern endourology. So Dr. Steffi, you can start sharing your screen. Until then, I'll introduce Dr. Steffi to you. So Dr. Steffi Yuen, she's from Hong Kong. She's recently the recipient of SIU Innovator Award 2025, which was awarded during the SIU conference recently. She is also associate member of the Working Group of Research and Publications EAU section of Endourology. She is also Vice Chairperson, Youth Committee, International Alliance of Urolithiasis. She is also a Japanese Urological Association scholar. She is committee member of Asian Urological Surgical Training and Education, that is OSTEC. And she's also an associate member of Asian Urological Society of Endoluminal Surgery and Technology, that is OSET. Steffi has more than 100 publications, and she is quite an expert in suction in RIRS and in suction technological methods. So I welcome you, Dr. Steffi. You can start your presentation. Thank you.
Thank you. Thank you so much for your kind introduction and for the invite for sharing. So I'll start the webinar with intrarenal pressure in modern endourology. So we've been doing ureteroscopy for the past years with no intrarenal pressure monitoring till now. So why are we talking about it now? So we look through the timeline. It's only until the recent 2 years that the first IRP monitoring ureteroscope is developed by Boston Scientific that gives real-time pressure monitoring. And we have known from previous animal studies and historical studies, and these experiments have shown that normal IRP would be lying around within 30 millimeters mercury. And you can see from these contrasts as well as ink-stained pathological specimens from dogs and pigs that there would be extravasation if it's going beyond 60 millimeter mercury or above, which causes pilovenous backflow and problems such as sepsis because of the fluid absorption, causing SIRS, fornixal rupture, and pain. We know that sepsis can kill. The recent publication on mortality from ureteroscopy shows that the most common causes is indeed infection and sepsis. And patient factors, this we cannot alter, but operative factors, including infection screening, prophylactic antibiotics, and etc., are reversible causes that we can look into. We've survived so far without knowing RP, but then comes a flexible navigable tip. So the first RCT comparing suction fans over conventional access sheath show that there's superiority, single stage, one stage stone-free rate, better quality of life, lower use of baskets, and also lower complications. There's also a multi-center study that we published showing similar results. We can classify intrarenal pressure monitoring devices as minimal invasive. Previously, older studies are performed percutaneous way, where they connect the pigtail, drain, or PCN to these IRP monitoring devices, usually used like urodynamic device or those used with anesthesiology or cardiology. But now we can have non-invasive devices that can be placed retrogradely. Wires are actually commercialized for cardiology or endovascular surgeries and not urology. But for urology, now we have equipped with scopes and sheath-based systems that are usually connected to these integrated suction irrigation systems. So now we're able to do studies in clinical, not just animal studies, and less invasive approaches. So a brief overview of how we can reduce intrarenal pressure. We can use smaller scopes with appropriate sized sheaths. We're not quite sure about patient positioning or table positions. There's not much literature on that. The traditional wisdom on emptying the bladder in obstructive systems, you would pre-stent or PCN would reduce the pressure as well. We have to have optimized fluid dynamics, such as inflow as well as outflow. But there are a lot of challenges. So in the publications that are written, the challenge is that we do not know what's the actual safe values. These 30 millimeter mercury cutoff is actually from animal studies. And a lot of literatures are not just using millimeter mercury. Some would use CM water. So it's very difficult to compare directly. And there's no standardization on how to calibrate. So when we do urodynamic studies, that's the oldest type of pressure transducers that we use in urology. But now we're using similar pressure sensors, mostly piezoresistive or optical fiber and scopes or sheaths, and less of the other types. So in urodynamics, we have a standardized way to zero things, but now we actually need to think of how to proceed with standardizing intrarenal pressure monitoring. We've done studies, experiments to show that it's accurate across some commercially available devices, and that the standard deviation is actually very small, and the intercorrelation coefficients is actually comparable, ranging from 0.91 to 0.97. The good points about integrating the intrarenal pressure monitors, sensors in the scope would be there's no learning curve. It's just like your normal scope, but these are expensive because they're mostly single use. We do have the Hawk L scope that has reusable ability up to 21 hours. But it does not come with an integrated suction irrigation platform. That's what we may be lacking in current literature. So these are videos of how it looks like. In essence, it will show a real-time pressure on the screen whole time, and it will have alert or flashing red signs if it's above the set limit of 30 millimeters mercury. So we've moved from conventional sheaths to suction sheaths to intrarenal monitoring pressure fans. So there are different brands and there are different configurations. I will not go into details, but you can look at the publications. There are different configurations of these pressure monitoring ports and also the mechanisms, causing maybe very slightly difference in the pressure monitored. But in essence, if it's a scope base, you can only have irrigation through the working channel, you have an alarm. But with the integrated systems, it can incorporate suction and intelligence because it can modulate the suction and irrigation. Probably we will have more information from the other lectures in this webinar. So apart from the well-known ports of the suction port, there's an extra port that we connect the intrarenal pressure sensor that is connected to the system. When you can monitor real-time intrarenal pressure, actually it can lower 30-day UTI rates. as shown by this propensity score matched study. And if you look into animal studies that we've performed using one of the systems, if we place these RP monitoring fan sheath in the upper, mid, lower calyxes and the renal pelvis, the difference is not more than 0.1 millimeter mercury. So if you're worried that you're not putting the thing at the correct position, it's actually not making that much of a difference in the pressure results. So one of the sheaths conduct the pressure through air instead of liquid. So you need to know which kind of RP monitoring fans you're looking into. But in essence, when you can monitor and regulate the pressure, we can use higher irrigation rate, which results in more effective stone retrieval. And because it's RP is regulated, it's within safe limits with very low sepsis rate from this pilot comparative study of 50 non-RP monitored and 50 monitored fans with the integrated suction irrigation. A closer look at irrigation parameters, suction parameters, and real-time intrarenal pressure monitoring and a non-pulsatile pump. In action, we usually flush the RP monitoring port with fluids for this settings. And after placement of the fans into the ureter, you'd also connect the RP sensor to this port after flushing it with fluid, and it would be calibrated to 0. You can see the real-time intrarenal pressure here. As I've said that there are different brands, so the site and location of the pressure measuring would differ. And if there are tight ureters and you cannot put the access sheath beyond it, this might result in different pressure monitoring. You can see that concurrently in a patient, I was using a Hawk RP scope and ZSR IMA sheath. You can see it's similar. Oh, so there's a it's 26 here. So the circle is not labeled correctly. So it's 26 and also 26 over there. Throughout the whole surgery, you can see there's only one spike when I place the fan sheath in, and also one spike when I remove the fan sheath. Throughout the whole surgery, it's stable within 30 millimeters mercury. Other systems like the visor system, you can see RP monitor here throughout. It's stable. You can see the system is not collapsed anyway throughout, but suction and irrigation is applied throughout the procedure. This is the graph showing a very stable RP line within the normal limits. And stone-free is possible immediately, and this is done immediately after surgery within 24 hours. So lastly, just an overview on suction, on SIP systems, the suction irrigation pressure regulating systems. Sheath-based systems, you can have manual and AI regulated, but these are costly. Scopes are even more costly, and they're usually thicker and needs to be used with bigger access sheaths. So the ideal system is yet to be found. Take-home messages is that the standard care for managing RP must evolve. We already acknowledge for many years that uncontrolled intrarenal pressure leads to sepsis and mortality, and this is not enough. We should be able to monitor and control, and how do we intelligently control it is to incorporate AI into our systems. We hope that zero sepsis and optimal lithotripsy efficacy can be used with these new SIPS systems for optimal fluid dynamics. And maybe we should look at RP as a vital sign and not just a parameter and use it to our advantage. So we do have an ongoing RP registry. Welcome all for collaboration. And these are my acknowledgements. Thank you.
Thank you, Steffi. That was an excellent talk. So for your session, for your talk, we have expert as Dr. Ravindra Sabnis. Sir is a very senior urologist from our country, and he's also a past president. He's chairman at the MPUH Center at Nadia. and he's also a member of the WCET for the South Asian countries. So I request Ravindra Sabnis sir to have his comments
Thank you.
on this talk. And thank you, sir.
Thank you, Abhay. I think this was an excellent presentation, and Dr. Steffi has really pointed out what exactly are the benefits of the monitoring the intrarenal pressure and how it can be done. I must say here that currently we have various systems which can be utilized. The pressure transducers mounted on the scope or on the sheath. But still, as she rightly pointed out, the best system is yet to be evolved. We still don't know which is the exact and the correct system to use in the clinical practice. The second thing which we need to really understand is that whether every case requires the pressure monitoring or not. Because we have done one study, and what we realize is that if you understand what exactly increases the pressure, then from next time onwards, you know that yes, you have to give a little pause, you have to wait for some time, not to keep on continuously pushing this. Judicious use of pressure pump or whichever system you are using it will eventually make your physiological pressures all the time in the limit. One thing which I want to mention here is that when we are talking of intrarenal pressure during RIRS, we also should not forget the intrarenal pressures during PCNL, because nowadays there is a serious race of going smaller and smaller in size of a sheath. And therefore, from the conventional, we have come to Mini-PCNL, we have come to MIPXS, Ultra Mini-PCNL, Micro Mini, and even the Micro PCNL. Now, as the sheath size goes down, we know that the pressures in the system, what problems we face is RISs also increase. And therefore, when we are going down into the size of the sheath, the intrarenal pressures keep increasing. We need to understand that there is an open system and a closed system. Whenever you use closed system, if you want to use a suction, you necessarily have to have closed system. And if your suction is not effective, then it is counterproductive, that it will increase the pressure. On the other hand, the open system where there is no suction use and the fluid comes by the side of the access sheath in RIRS or the PCNL sheet during PCNL keeps the pressures quite low. But it all depends on the outer diameter of the telescope and the inner diameter of the sheath. If that gap is not more than 3 or 4 French, then you are bound to have the buildup of the pressure even when it is an open system. So when we are talking of the endourology and the pressures monitoring, these are the factors which we really have to look into it. And I'm sure as we proceed and as we do more and more cases, the things will get evolved and we will come to a conclusion as to this is the correct method of using the pressure system, the timing, and the various ways, the surgeries and the scopes that we are going to use it. Thank you very much. That is what I wanted to say.
Thank you, sir. Point well appreciated. So there is one question from the audience. Keshav Murthy sir has asked one question, that the size of the scope increases if you integrate all these devices into the scope. So are there any devices which have retained the size of the ureteroscope plus which have added all the devices to monitor the pressure? So Dr. Steffi and Sabnis sir, both of you can answer this question.
Thank you for your question. So it's not commercially available, but I've done pilot studies on some first-in-human studies. A device from the USA and another device from China, but these are not commercially available yet. And they can keep the size of the scope down to 7.5 with all the functions that I've mentioned. So it's possible, but it's not commercialized yet. But it's worked really well in first-in-human trials.
See, I will add a point to it, that what she has said is right. It is counterproductive. On one hand, you want to reduce the pressure, but on the other hand, you keep on increasing the size of the scope. So Biorad has come out with the 8.3 French scope, and they are now trying to make a 7.5 scope with the pressure transducer on the sheath. But these are all okay for the fans using sheath. But if you use in-scope suction, then obviously if you reduce the size, the channel size is going to go further down. And then the suction, what you are going to get through the channel is completely fallacious and is of no use. So if you really have to talk about the sheath, yes, the size may go down, but the inner diameter of the or the access sheath, if it is appropriate size, you can have effective suction even with the smaller size of the scope.
Thank you, sir. Thank you, Steffi. Thank you, Sabnis, sir, for your comments. So we move on to the next speaker, Dr. Vikram Sridharan. He's going to speak on suction techniques in RIRS, that is DISS as well as fans. So Vikram, you can start sharing your screen till I introduce you. Vikram has graduated from Ramchandra Medical College in 2008. He's a consultant urologist and endourologist at Sri Paduka Hospital, Trichy. He has been invited as speaker and operative faculty at several live operative workshops across the country. He's a founder member of Trichy Urology Education Foundation, that is TRUE, and is chief instructor in TRUE Endourology Fellowship Program. The expert for this session is Dilip Kumar Mishra. He is one of the council member of Urolithiasis section of USI. So over to you, Vikram. You can start your presentation.
Yeah. Good evening, respected teachers, dear friends. At the outset, I would like to thank the USI, the Urolithiasis subsection, and the ISU for giving me this opportunity to talk about the use of suction in RIRS. So this is just a brief view of the EAU guidelines for treating intrarenal stones. And the RIRS versus PCNL debate is always going on. And for us to understand where the fans or the suction stands, the first question is, what is the need for suction? All these years we have been doing RIRS. What is the need for suction? For that, we need to understand what is the disadvantage or limitation of our conventional RIRS. One, as already mentioned, it is a poor vision, especially in large stone burdens where the dust itself covers the stone particles. We are unable to hunt for further stones. It becomes more difficult in yellow radiolucent stones where the golden dust becomes our own enemy. And due to this and other unfavorable anatomical causes, we can have incomplete clearance. Imagine breaking a few fragments in the lowermost calyx, which is dependent, and at the end of the day, it doesn't get cleared. And obviously, for the quest of increasing the vision, we increase the intrarenal pressure, leading on to sepsis. So now the question is, how do we reduce or decrease the disadvantages of RIRS? There comes the suction. We have two ways. One is direct in-scope suction technique. It can either be done manually or using a suction irrigation pump. And another thing is the fans, flexible and navigable access sheet. At this juncture, I would like to thank Dr. Vineet Gauhar. He introduced me to fans sheet way back in end of 2022. But till mid of 2023, I was very skeptical. I was afraid to use the fans sheet, thinking about various possible complications. Till the day I started using it, the first case I did, I started falling in love with fan sheet. Now coming to the manual suction method of DISS, the direct in-scope suction technique, I thank Dr. Parimal Garia for letting me use this image and the video following this. He has done an excellent assembly of the manual DISS, where the scope is attached with a three-way lure lock, along with a 10 cc syringe, which is used for suction, and then another 100 centimeter extension and a 20 cc syringe used for irrigation. And it is in turn connected to a TUR set with a 1 liter NS. It is very easy to assemble. Even in the nth minute, we can assemble it in the OT. It is compatible with all brands of flexible scope, works very well practically, very, very usable. The only disadvantage I would mention is we need good assistant to be aligned with the surgeon to use the suction as well as the irrigation. And the intrarenal pressure is really unpredictable because the assistant is using it. So this is another video. Again, thanks to Dr. Parimal. Here we can nicely see as the assistant is using the suction syringe, the vision drastically improves. Here there is no way that we can measure the intrarenal pressure. But this way, we can really keep the vision under control and the intrarenal pressure low. There are many companies now coming out the integrated scope connector. Here, this is one prototype of the Biorad company. This was made in India. It is attached to a suction irrigation pump, which can be controlled with our index finger, the surgeon's index finger. So there is a continuous irrigation as well as suction. The surgeon can toggle between irrigation and suction. As you can see, this is a yellow dusty stone, but the vision always stays intact. I'm toggling between the suction and the irrigation. So as and when I'm breaking the stone, I use the irrigation, and then I suck it whenever the vision is disturbed. Oh, this is another small clipping to show how that suction in that prototype worked. It really worked very well. It was very impressive. We can see there are lots of dust particles, and the fragments were buried beneath that. Once we suck the dust particles, the fragments are nicely visible. Now the surgeon, without raising the intrarenal pressure, can have a very nice vision and break the stone further. So there are a few other companies coming out with the inbuilt suction technique. Coming to the fans, the flexible sheath has a flexible end. The access sheath has a flexible end. It can bend and enter almost all the calyces. The suction end can be attached to our regular OT central suction or to any suction machine. The length of the access sheath is longer than the regular access sheath that we use. Almost no learning curve, except that when we introduce the access sheath, we have to be little careful not to injure the calyces. It can be used with all the digital scopes. So unlike the DISS, which is inbuilt, this can be used with all the digital scopes and available in various sizes. The disadvantage being that there is no guarantee that we will be able to place a fan sheath even in a stented system. There is limited sheath life and more damage to the flexible scope, and it's really bothersome because we reuse our flexi scopes. So this is a small clipping, a very large 3.5 centimeter yellow dusty radial lucent stone and a pre-stented one. We are using the fan sheath. One can see the moment we start breaking using the laser, the dust starts coming, entering the vision. But we are continuously increasing the irrigation as well as the suction is connected so that our vision stays intact throughout the procedure. So in this surgery, the surgical time was really decreased, and those small few fragments which were left behind at the end of the procedure, because I used a holmium laser. So all these fragments have been sucked out through the fan sheath, thereby giving a complete clearance in single sitting. Another frequently asked question is whether we will be able to take the fan's sheath to the lower calyx. So this is one small video clipping to show that the fan sheath fantastically bends along with the flexible scope, and we will be able to take it to any of the desired calyces, and it stays intact in the same calyx till we reposition it. So I prefer not to connect the suction in the initial stage, and I leave it as a passive drainage. Just the intrarenal pressure stays intact or little low, because the moment I connect the suction, there is collapse of the system and a little disorientation. So I would prefer to keep it this way and activate the suction towards the end of the surgery. This was the first case where I used fans, and I fell in love with it instantly. So one can see a large upper ureteric stone, multiple renal stones, and almost all the calyces, a very large stone burden. The patient was pre-stented, and the fan sheath was used, and we could give a complete clearance in one sitting. Another case, large post-PCNL residual burden, so where we could use the fan sheath and give a complete clearance. Large upper calyceal compactly placed stone, we could give a complete clearance using fans. Again, there are a few questions about usability of fans in complex renal anatomy. So this is a pelvic kidney with an impacted renal pelvic stone. So this is the RGP image. We had a little bit of trouble introducing the fans through the PUJ, just below the PUJ, but after repeated attempts, we could take it across, and the fans could be taken to every calyx of this pelvic kidney. And once we can visualize the stone, then it becomes like any other normal surgery where we start breaking the stone and sucking out the dust in the fragment. So another complex residual stones, post-PCNL residual stones, we could use fans and give complete clearance. Now the question comes whether DIS or fans. Now we'll understand the disadvantages and advantages of both the systems. Direct in-scope suction technique is very useful in primary sheathless RIRS and in unstented systems, or in tight ureter and PUJ even after stenting. So those cases, this is very, very handy to give a complete clearance and improve the vision. And it is very helpful and difficult to reach calyces because fans sometimes may not be able to reach in a narrow infundibulum, a long infundibulum. This is very useful. In my personal opinion, this works better with TFL because TFL creates very fine dust. The disadvantage is being unpredictable renal pressures. It is little time consuming and it is scope specific. A small tip is to keep the laser fiber in situ while sucking the dust. Otherwise, we may damage the working channel. Coming to the fans, it is a predictable sure shot on-table clearance even in large stone burden. It continuously maintains a lower intrarenal pressure. Works better with holmium because the holmium fragments the stone. We can remove the fragments in toto and thereby aiding the faster clearance. And there is no learning curve for this and works with any digital scope. The disadvantage being it needs pre-stenting, but there is no guarantee for entry even after stenting. The scope life really is reduced after using fans and reduced life of the access sheet. We used to reuse the access sheets earlier. Now we have to throw it off even after limited use. And it may not be suitable in all the cases. Thank you.
Dilip, your expert comments.
Yeah, thank you, sir. Thank you for the opportunity. Vikram has given a very excellent talk and he has covered both the things very well, dis and fast. Just a few points on dis, because we all know that we are doing intrascope suction and this channel is very small. So it should just be sparingly used to reduce the intrarenal pressure and to clear some amount of dust if possible. I think we should not go ahead and use it extensively for clearing the stone fragments. The second thing regarding fans, as Dr. Vikram has nicely elaborated on each and every aspect, I would just say one thing. It has come up very well. It has brought RIRS almost an equivalent platform to PCNL because initially PCNL would clear all the stones in one go, but RIRS will not be able to do so. But with fans, we are able to do on-table clearance at the same go. And I would just say one more thing that in fans, as he said that he does not connect suction all the time. I would connect suction all the time, but I would not activate the suction. As well as I would also, what I want to say. And there is one more thing which is coming up, which we have seen that is called Calyxo CVAC system, which is a latest system. And it is, although it's a very huge system, like 7 French tract is there inside the scope. And you can do all the sucking and all the laser fragmentation at the same time. And it is one of the most upcoming system, which also is like, you can say, combined of fans and this at the same time. That's all I would like to say. Thank you, sir.
So there's one question from the audience from Ahmed Marzu. So he's asking, sometimes, especially in males, if the suction sheath isn't sufficient to reach in spite of good dilatation. So what's your suggestion, Vikram?
Dis. So we just go ahead with the regular RIRS or use a dis in that particular case, where Dr. Parimal's technique of assembling it instantly helps a lot.
Yeah. So thank you, Vikram. Thank you, Dilip, for your nice comments. So we move on to the next speaker. Thank you. I would welcome Dr. Jia-Lun Kwok, and he's going to speak on integrated irrigation suction pump, flow control and efficiency. So till he shares his screen, Dr. Kwok, I'd like to introduce Dr. Kwok. He's a consultant and endourology service lead in the Department of Urology, Tan Tock Singh Hospital, Singapore. He's completed his 1-year endourology fellowship at University of Hospital Zurich, Switzerland. He's program director at the adjunct lecturer at the Nanyang Technological University, a clinical teacher at National University of Singapore. And he's in many collaborative groups like PERS, associate member of section of EAU Endourology and associate member of OSET. He's reviewer to prominent journals like World Journal of Urology, Urolithiasis, BMG Urology, European Urology, and many more. So welcome, Dr. Kwok. You can start your talk. And the expert is Dr. Pankaj Maheshwari. He's a very senior urologist from Mumbai, working at Fortis Hospital. Welcome, Pankaj.
Good evening. Thank you for having me. I hope you can hear me loud and clear.
Yep.
Thank you for the invitation today and talking about integrated irrigation suction pump, flow control and efficiency. So essentially, literature procedures have progressed. Essentially, we're talking about flexible uteroscopy, PCNL, ECRS, and cystolithotripsy. We're talking about the choice of lithotripsy strategy, and the era of adjuncts has come in terms of fans, DISS, suction PCNL, and then underlying it all, suction. So the trifecta of stone surgery, in my mind, you really want to be stone-free, single stage as much as possible, as well as to decrease complications, and of which one factor is intrarenal pressure. And you want to be able to know intrarenal pressure, and two, to be able to control it. So suction has come into play, and that really is a correlation between intrarenal pressure as well as suction. As we know, as we talked about earlier, that intrarenal pressure matters. Pilus venous backflow as well as pilotubular backflow happens at higher IRPs with these dye stains. And in terms of what the evidence was, we talk about a kind of recommendation of 40 cm water or 30 mmHg to be the kind of value that we looked at. We know that in utroscopy, actually intrarenal pressure varies. And in this nice study, you looked at the variation in utroscopy. You find that actually with manual irrigation, actually the pressure goes much higher. And you can see the baseline wise actually can go much higher compared to 30 mmHg. In terms of in vitro studies, of animal studies, in terms of evaluating different kinds of factors, no sheath actually is the worst. And within the renal, calyx is actually, the sheath location is actually better. We talk about irrigation being manual, irrigation being the worst in terms of the highest pressure that is associated with. We talk about fans, and actually, do we think that with fans, pressures will be low all the time? This is a nice study that really talks about IRP still possibly being high with fans. So we do therefore possibly need to talk about intrarenal pressure. The classic has been the ureteroscope we've used for many years, but now we have moved towards a video processor and ureteroscope being integrated. And we used to use suction, irrigation, and now we have suction inside. We moved towards a situation where actually we're trying to integrate irrigation, suction, and a pressure monitor within one single machine. So it's important to know your equipment. We alluded to it earlier. Is it mmHg? Is it kilopascals? Is it cm water? You need to know equipment. The second thing is that, are we being precise enough? Are we looking at a clock phase that is an analog? Are we looking at a digital clock with the seconds as well as the day? So precision may matter now with fans, as well as higher pressures that we are using with suction apparatus. I mean, the various integrated irrigation suction systems, as we talked about earlier with the GLID system, which is through the scope, which ultimately stops irrigation blockage. And we talk about fluid dynamics being important. We see the top picture. I mean, it's not a situation you want to be in with a collapsed system with oversuction. And you would like to be in the bottom part of the image where actually you're dusting quite nicely, getting a good view, getting the dust particles out at the same time. And with fans, it depends on the RESD between the scope and the sheath, the collapsibility and compliance of the renal system, the cavity volume that you're looking at, as well as irrigation in and the suction and the balance with IRP. So there are various systems that have come up. This is by Boston Scientific, is a Suris using the LithoView Elite, talking about its automated irrigation with real-time IRP monitoring and flow regulation. What it does is it talks about IRP monitoring, and when the pressure is high, it cuts the irrigation. And so this seems to be kind of the mechanism that most machines are moving towards. So the need for IRP monitoring, particularly in dual channel scopes, may be important. If you have a dual channel scope with one way in and another way out, if your outflow is actually blocked and you don't know about it, your continuous inflow may cause very high intrarenal pressures. And if you don't measure that, it may not be very good for the patient. So IRP via fans or scope, this is a paper by Dr. Yuen, essentially LithoView Elite Zebra Scope IMMS system, and so the tidal system and urodynamic system, and actually all seems to have been reliable and all seem quite congruent. So we are quite good in terms of correlation between different machines as well as different ways to measure IRP. Via the scope, as mentioned, is LithoView Elite Zebra Scope L-type first. But the problem with measuring IRP through scope is that we are getting smaller and smaller. So can we fit a pressure transducer? Can we fit a working channel, or two working channels, light sources, which usually is two, a camera, and how can we fit in that real estate in the tip of the scope? So that's a challenge with scopes. Therefore, we possibly talk about using fans, and there are two systems that we'll talk about in this paper. There's our IRP and the IMS system, as well as the tidal system. I use the IMS system, so I'll talk a bit more about it today. It's an integrated system via the sheath with regulated inflow and suction with a cavity pressure setting. What do I mean by that? So it means that if you set irrigation pressure settings, both in terms of mils per minute flow as well as the pressure, you put a negative pressure setting, either by liters per minute or a suction pressure, but you set a cavity pressure setting that you want the system to be keeping at, and you auto-regulate that based on IRP that you're monitoring. So these are important to note that it's the seeding settings that you're setting at. So the machine tries not to go above those settings regardless of irrigation, suction, or the cavity pressure. So this is how it looks like in real life. You may look at a lot of numbers, but if you look at the color coding, it's quite important. And the color coding shows that the green is actually the irrigation flow in, real-time pressure. The white is showing the out, which is the suction flow, the real-time suction pressure, and blue is the real-time IRP. So this is a fan sheath, and if you look at the third port, which is a IRP monitoring port, that is a wire, that's a pressure wire that goes all the way to the tip, and you see the apertures at the tip, that is where the pressure is sensed. So this is a setup that I use for my OR, with the pump at the side, and you select the mode, the flexible endoscopy mode, and subsequently you start the flexible endoscopy mode, and then you set the irrigation pressure and suction pressure that you like. First, what you do is that you have to calibrate, or you have to flush the sheath with water, in this case for this system. So as mentioned, different systems have different kinds of calibration. And then you insert the sheath as per usual, but in this case, you attach a IRP connector to this third port, and then subsequently you attach a suction port as per usual. And subsequently, you actually attach the IRP monitor to the machine and it starts at 0, and then subsequently you put your irrigation pressure as well as the suction pressure, and you see what you like. And this is a very precise kind of touchscreen where you can put exactly what you want as a values. And irrigation and then suction is on, and it's real-time monitoring, calibrating your inflow pressure as well as the suction pressure to not go beyond the 30 mmHg that you've set. So this is how it looks like in real life, going into the system, and then you can see that it's real-time monitoring. But to ask me, do I look at this all the time during the procedure? I don't, because I trust the machine and it does that for me. So actually, I don't have to look at that sort of pressure anymore. It takes away that fear away from the pressures that you have. So intraoperatively, these are some pictures of quite nice dusting as well as clearance of view, and subsequently suction of bigger fragments, as well as activating the suction and then getting fragments out. And likewise, this is evacuation through the sheath, which to me is the most tedious part of fans, and it helps in terms of the irrigation and suction outflow and the gradient to get out fragments nicely. So likewise, these are some intraoperative videos of suction with the flow regulation at the machine and fragments coming out via the sheath quite nicely. And likewise, same here as well. And so therefore, it really offers kind of a flow regulation. And my eyes are not really on the machine, it's really on the screen, because I kind of trust that the machine will auto-regulate it for me. So it's important that you need to know a machine very well. So in this case, I went up with a fan sheath, and I went up, and first thing I saw that it was totally collapsed. And I was wondering why, because the pressure was super, super high. It was like 90s to 100s. And I was wondering, why is the IRP so high despite it being collapsed? So first thing I did is actually I removed and I took off the IRP monitor. I was trying to troubleshoot, and I found out that actually if you look at the right-hand side at the 2 o'clock, there was a piece of tissue that was stuck in the IRP monitoring aperture, and that caused an artificially high pressure. And therefore, I think it's also important as you use your machines, whichever system you use, to be in the know of how it measures the pressure, as well as what it does when pressure is high, and you're able to troubleshoot. So fragment evacuation is the most tedious, as I mentioned. So RESD, withdrawal speed, inflow, and suction gradient is important. And I come from PCNL training, and actually when you have Mini-PCNL, you find the fragments are not coming out, and this is a non-suction system. I actually increase my irrigation height because I think that will increase the flow, and that actually is what maybe is better for fans if you're having difficulty with evacuation fragments. And with the IRP, knowledge is power, and I think you're able to increase inflow and suction in line with what I said, because you are trusting that the IRP be measured. So for example, on the left side, my usual pressure settings are 150 in, negative 120 out. In this case, if fragments were coming out very nicely. So I increase it to 180 in and negative 140 out. But with that, the machine actually auto-regulates to -4 to 0. And that allows me to trust my machine and allows me to go to higher settings to increase my efficiency of my procedure, yet being kind of safe. So otherwise, you can actually use the machine in non-IRP monitoring situations, just as an irrigation suction pump. You can use it in semi-rigid ureteroscopy, just as an irrigation pump, and a sheathless IRS with just irrigation. So there's important factors when I use the machine because I can use it for all endourology procedures. So really, lithotripsy procedures have gone on to adjuncts, but more than just suction, I think it's also about irrigation as well as intrarenal pressure as flow regulation. As we go on, the classic and good has been this, but we've got more and more things added onto uteroscope or the sheath itself. I think that GUI, the graphical user interface, is key. You really need to keep it super simple. It's too complicated. It's very hard to understand. It takes time and as well mental capacity away from the real procedure itself. So there may be a GUI integration in terms of looking at values on the screen, which may make things a bit easier, and other progressive integrations of IRP, temperature, as possibly suction within one scope. So multi-platform purpose platforms are kind of happening as well as possibly is the present and the future. We're looking at pressure monitors, temperature monitors, possible laser integration, which is coming up. And the pros are really OR space, cost benefits, possible safety, but also we need to think about the cons. Are they compatible with different brands? Does it limit your choice to upgrade? Is it too complicated? Is it really needed? Training and to set medical legal kind of boundaries, that is still to be discussed. So my take-home message is essentially that this is a shifting paradigm for multi-purpose platforms. I think it's efficiency and safety with IRP monitoring with integrated systems and really simplifies the irrigation and suction balance. However, you really need adequate training. You need to know your equipment, how it works, and how to troubleshoot it. And you should keep it super simple in terms of your graphical user interface. So flow auto-regulation is likely the way ahead for efficiency to increase. So I welcome everyone to join the Suction ECRS database. Please do contact us. This is Suction ECRS. If not, I thank you for your time and thank you once again for the invitation.
Thank you, Kwok. It was a great talk. Over to you, Pankaj, for your
Yeah, I agree, Abhay. It was a wonderful compilation and fabulous talk on this new innovation where irrigation, internal pressure, and suction is being really automated and combined in a single machine. In this today's time when RIRS is being used for larger stones, probably such an innovation is important because that will help us reduce complications, get a better vision, and also get a higher stone-free rate. So you partly answered my question, Dr. Jia. If suppose the pressures suddenly go up, you said the irrigations would reduce. In such situation, there is a theoretical risk of temperatures going high. So what precaution do you take to prevent such a situation? Because if you continue with your laser lithotripsy with irrigation stopping, then you would expect the temperatures to go high.
I think the first thing to understand is why is the pressure high? Because if it's a fan sheath, it shouldn't be high. So I think once you troubleshoot to see is your machine reading the correct thing? Is it the channel being blocked? The second thing is that whether or not your suction is enough in that case. So I think one is if your suction is too high, you need to down the suction. That's correct. But also perhaps also need to down the suction so there's still flow regulation. The other thing to this is that with good flow, definitely the temperatures will come down. But in a situation where you have very bad flow, then one needs to be very careful about laser settings, particularly in DISS. I think that's particularly important because until the time where intrarenal temperature is widespread, the only control you can have is flow regulation as well as your temperature settings in terms of your laser settings because that directly contributes to the temperature. So keep your laser settings as low as you need. Bring it even lower in a situation where you have decreased flow.
So among these parameters, you would feel the flow is more important than the temperature. It means if I have to monitor something, monitoring flow is more important than monitoring the temperature.
I agree. I think with good flow and with the caveat that you need to control your laser settings, I think then the temperature may be less important, particularly if it causes an issue or access to equipment is the issue. But it's a pairing of both your flow regulation as well as your laser settings that you're keeping to in a safe way. So I think laser settings are paramount as well.
Great. Thank you very much.
Thank you, Kwok. Thank you, Pankaj. Thank you. It was a nice session. So we move on to the next talk, that is complications of suction in RIRS by Deepak Ragoori. He's a senior consultant from AI in Hyderabad, and he's going to speak on complication. There is already a question from the audience by Siddhartha that does the suction causes damage to the calyx? And I think this is the right time for Deepak to tell us the complications. Over to you, Deepak. And the expert is Dr. Chandra Vaddi. He needs no introduction. So Chandra, please take over.
Yes, sir. Deepak, please. Deepak?
Yeah, can you hear me?
Yeah.
So just introducing myself and saying thank you for the opportunity given by the USI ISU and the Urolithiasis subsection. And I welcome on behalf of Urolithiasis subsection as a council member to all the international faculty and the delegates. So I'll give a brief talk on complication of suction in RIRS. When we say suction in RIRS, primarily we are looking at the devices that the suction happens in RIRS in terms of the scope itself, or primarily I'll be focusing on the access sheath that delivers the suction mechanism in RIRS. Yeah, why suction? In the first place, I guess we have had enough introduction on why suction. The problem we are trying to deal with in RIRS is about the residual fragments, the potential infection and sepsis in these cases, and the ever-growing concern on intrarenal temperature and pressure, the poor vision in cases of where you're trying to attempt larger stones, or the snow globe effect, which we call, and the longer operating times. This is what we have traditionally been having concerns as far as RIRS is concerned when you compare with PCNL, like Professor Sabnis has rightly pointed out. Now, what's the promise that these suction devices are giving us? So it's an improved stone-free rate, in fact, an absolute 100% stone-free rate in some instances, decrease the episodes of sepsis and septic shock maybe, controlled and decreased intrarenal temperatures and pressures, a better vision for a better surgery, and which eventually will cut short on the operating time. But let us understand, does adding suction change the complications of spectrum per se as such with already existing access sheets? Or maybe does it simply modify the existing risks that are already there with the access sheets that we have been using? So let's come to the truth. The complications are fundamentally the access-related complications in this scenario. It could be an ureteral mucosal injury, it could be a perforation, it could be bleeding, it could be ischemia due to a prolonged dwelling time of the access sheath, irrespective of whether it is a suction or not, eventually leading to an ureteric strictures. These are something which we clearly know about the access sheaths all these years. But suction does not eliminate access-related risks. It's only an addition to the existing access sheaths mechanism. But what remains the same is the insertion-related ureteric traumas. The size mismatch injuries, more so in suction devices, because the initial introduction where your 11 and 13 French access sheaths, however, the sizes are going down by the day, but the lengths are definitely on a higher side. And if you don't understand the dynamics, you will definitely damage the pelvic calyceal system when you try to over-insert the access sheaths beyond the PUJ. The ischemic risks predominantly stays more so if you're trying to use a larger sized ureteric access sheaths, and the bleeding component still remains the same. The post-operative pain adds to the pain actually if you are using a larger access sheaths, and of course you will be failing to negotiate through the narrow ureters. A suction sheath is still a sheath. It doesn't make any difference as far as the sizes are concerned. What may be different? Let us look at a mechanism-driven or mechanism-based view here. We could look at access mechanisms or mechanics, the pressure flow dynamics, a flow suction balance, and a surgeon learning curve. I would broadly classify the concerns under these headings. If you have to go one after the other, the suction introduces new dynamics of forces rather than new anatomy. We are dealing with the same anatomy we have been dealing all these years. But the negative pressure that the suction access sheath gives may add to the challenges. The flow suction balance will also add to the balance and regulation of how a surgeon can tackle this. The positioning of the tip of the access sheath, I feel, is crucial. Dr. Vikram actually highlighted this point that he prefers to stay well below the UPJ even before he would like to activate the suction. That's a very good take-home message for all of you. And the duration of suction that you're going to, whether you're going to do intermittent or you're going to go on with a continuous suction, will determine the complications that you have. Now let's list out the complications one by one. Now, this has been an age-old slide from Professor Traxler, which is stuck into our brains all through these years. He's posted this way back in 2018, and nothing has changed in the last 8 years as far as this ureteric access sheath and ureteral lesions are concerned. We do have some classifications which are simply put in grades of 0 to 4, and this picture depicts beautifully from a no ureteric lesions to a total ureteric avulsion. Now, this can happen with any access sheath, that includes even your suction access sheath. But the more challenging concerns, I would say, are the mechanical failures. The tip can buckle and bend, provided if there is any concern as far as the stylet is concerned, or if any manufacturing defect is there. The buckling and tip bending can cause an ureteric trauma, and its failure of getting into action the flexible component of the access sheath, it could be again a malfunction. A suction failure, it comes at the level of the vent or the pinch valve mechanism that we have, and this suction failure can automatically lead to some challenges. A sealing cap damage, which is not airtight. The sealing cap is the one which is at the fag end or the access sheath, which we remove the stylet, put back the sealing cap, and then introduce your scope, which keeps the suction intact. Now, if you don't use this, the water leaks continuously backwards. That doesn't give you an adequate suction effect. I would say more of a limitation rather than a complication, and an ill-fitting stylet cannot allow the access sheath to go in completely. When you come to the negative pressure complications, the mucosal tenting into the access sheath can happen, where you suck in and the mucus comes into the access sheath, which can result if you can realize it very early and let go the suction, there's not much damage done. But if it constantly is happening, you will cause some chelical trauma. It is a localized mucosal trauma, or by using a damaged atraumatic tip in the suction ureteric access sheath. I'll just show you a small clip on this. There is a soft tip for all these suction sheaths, which is actually preventing from any further damage to the mucosa. It is also actually a cutoff mechanism for your suction. Now, considering these are single-use sheaths, obviously, but these are considered as a limited-use sheaths. We tend to reuse them. Please keep an eye on the tip of these access sheaths. If it is damaged, please do not use those access sheaths. They do cause more of a damage. And this can result in a fornicial bleed when you enter all the way into the calyx and rupture the fornix. And the ureteral wall grabbing can also happen if it is falsely positioned in the ureter and then you keep activating the suction. So this is what I was talking about, the collapsing tip of the suction access sheath. Just look at the tip. As and when you activate the suction, the tip collapses. This soft mechanism is for actually a safety mechanism rather than anything. And if it is damaged, you're definitely going to damage your ureter. Coming to the pressure dynamics paradox. Do you think that the lower global intrarenal pressure equates to no injury? I don't think so. The overall IRP is reduced, agreed, as far as this access sheath is concerned, but there is a localized transient pressure gradient which is always there and can result in bleeding. So near the tip of the sheath, yes, that is where the actual dynamics are happening, but the rest of the pelvic calyceal system, you need to watch out. What's the potential threat? Yes, it can be used in these infected kidneys and elderly patients and thin-walled pelvises in some of the individuals where, in spite of keeping the pressure low, these kidneys can give way. So be watchful of what kind of kidneys you're doing. Are there long-standing obstructed kidneys, any anomalous kidneys, where you expect these kidneys to be more fragile? Be very careful in those. And it only highlights the importance of controlled suction. And the fragments, when you're trying to evacuate the fragments too early in your procedure, you can have these fragments trapped in between your access sheath and the ureteric mucosa. An over-enthusiastic suction can result in complete loss of fragments. Maybe if you want for analysis, you might not get them. A premature aspiration can cause larger fragments coming out and getting stuck, and the sheath might get clogged, and there is a loss of time in operation. And suction interruptions and blockage can happen if these fragments tend to block your access sheath. And learning curve complications are also one of the things we should consider. Using an access sheath does take its own sweet time for getting a hang of how to use it. An inadequate understanding of these suction access sheaths can result in any of the challenges we discussed. And overconfidence in using with this access can also result in some issues. And poor sheath tip positioning, like I keep telling that you need to get a hang of this before you start getting confident. Continuous maximum suction usage can also result in a collapse of the system, and then the tip of the access sheath giving a traumatic experience to the pelvic calyceal system, and an inadvertent trigger of the suction without you realizing. When you keep holding the suction access sheath with your hand, your thumb at times close the pressure vent without your knowledge, and then the suction is constantly activated. So watch out on how you hold these access sheaths. Coming to the evidence, there is enough evidence to say that the suction ureteric access sheaths have better stone-free rate. There's no doubts about it. It could be immediate, it could be after a month, or even after 3 months, they definitely score over it. And this recent study, and Steffi is here, and she's been involved in this study on impact of suction ureteric access sheath in ureteroscopies, a systemic review and meta-analysis. This also says that the overall complications rate is less in suction ureteric access sheaths. However, there is no change if you look at the septic shock or hematuria component. But they do conclude saying that we definitely need more RCTs to conclude on this. This is an evolving technology. I think a lot of studies are coming in. We'll understand it more and more as we go forward. But till then, watch out. But where are these complications actually coming from? I must say it is maybe your patient selection of your access sheath size, forceful insertion of sheaths, a prolonged duration of surgery. You get carried away because the suction is active, the pressure is less, the temperature is less, but you lose a track on the duration of surgery. That doesn't mean that you can go on and operating just because the pressure is low. Watch out for the ureters, and inappropriate suction strategy can also lead to this. So what are the prevention pearls that I might say? Use the suction intermittently, avoid continuous suction activation, position your tip of the suction access sheath below the PUJ, decompress the infected systems if at all there is debris in it before suction, even if they are pre-stented. Choose the size on a conservative size rather than going on a higher size, and monitor your flow suction balance. What we still don't know, maybe long-term ureteral perfusion effects. We are still digging deep into this. Standardization of suction pressure limits, data on prolonged procedures and its impact on the ureters, impact on narrow ureters, and adaptability of the technology is a challenge because the tech is moving just too fast. You need to slow down when you are not understanding this. Absence of evidence is not evidence of absence. So I would say that suction UAS per se does not create a complication, but it just amplifies the consequences of a poor technique. When used thoughtfully, benefits definitely outweigh the risks. Technique and not technology determines the safety. Thank you.
Thank you, Deepak. Nice talk. Your expert comments, Chandra.
Nice talk, Deepak. First of all, I must thank the USI and ISU for giving the opportunity. An excellent webinar. Suction actually is introduced to reduce the intrarenal pressure, but misconception in the juniors that you can use the suction and get away with the problem. Primary factor is the inflow. If your inflow is more and fraction of second, if you are not sucking the fluid, it may raise the pressure. So one should be cautious. Otherwise, most of the points are covered by Deepak. One more important, the suction in PCNL and RIRS is different because 50 centimeter length, if you want to suck a small fragment, you continuously need to put the water into it. The person who is putting it does not understand, and if the surgeon is expecting that the fragments will come out very fast out of the sheath, disaster can happen. You should come out slowly. The fragment has to come out slowly. It has to come out. It will take time. So seniors are mentioning that do, like Deepak also mentioned, do the powder as much as possible. Keep it sucking intermittently. Last few fragments which are there can be sucked out. So use cautiously. Don't take it for granted that all the patient. In children, I have seen entire calyceal system comes into in 1 second into your mouth. Their PCS is very small. So it's much more dangerous, especially at the PUJ region. Overall, Deepak, well covered all briefly in 8 minutes. Thank you.
Thank you.
Point well taken, Dr. Chandra. Thank you, Deepak. There's a small question short question from Rohit. That will the suction work if you keep the tip of the sheath at PUJ?
No, we are not trying to say that the suction is going to work at the level of the PUJ. You are going to keep the suction at the level of the PUJ only to make sure that your lasing is happening in the PCS, and you push it up to the desired calyx or the position when you want to activate it. I'm only trying to say that don't push it into the PCS at the first instance when you start the procedure. That's the point.
Yes. Thank you, Deepak. Thank you, Chandra. We move on to the next talk by Dr. Rohit Joshi. Rohit is a senior consultant urologist from Ahmedabad. He has his own hospital, Arna, and he also conducts training programs known as Class A. So, Rohit, you are going to speak on suction in Mini-PCNL, and the expert is Dr. Rajesh Kukreja, again, senior urologist and secretary of the Urological Society of India West Zone Chapter. So, Rohit, start sharing your screen.
Yeah, can you, I presume my slides are visible and I'm audible, sir.
No, you will have to share the presentation.
Yeah, I already shared it, sir.
We are not able to see your slides, Rohit.
Can you
Yeah.
see this now?
Yes,
Yep.
yes, you can start.
Okay.
Yes.
So
Thank you.
at the outset, let me thank USI, ISU, and Urolithiasis subsection leadership for this fantastic webinar and the opportunity to be a part of this esteemed faculty panel. I'll be brief as instructed by Abhay. So Abhay, suction in endourology, a fantastic and a very relevant topic to say the least. But most of the focus of our discussion was still now happening in suction in RIRS. But this is, equally important in PCNL as well, especially when we are talking about mini-PCNL. Give me a moment. The slides are not getting forward. Give me a moment. Yeah. So, friend, we are all clinical scientists. We are working in clinical setting, but we keep on inventing things when we feel there is a necessity. Then we come across some limitations, we improvise, and then we come out with some innovation. So that's what we are. We are clinical scientists, and this is the evolution happening in the surgical management of stones. Initially, there was open stone surgery, then came PCNL, then came shock lithotripsy. Again, PCNL came with some modification like mini PCNL. Then RIRS came as a big and gave a big fight to PCNL, and then once again we are here with section mini PCNL. So these things will keep evolving. So many times PCNL was considered to be a dead. So initially, when shock of lithotripsy came in a big way, it was thought that PCNL is going to die, but PCNL is a phoenix bird, so it got rebirth as the mini PCNL. And then after a decade or so, when the RIRS came, again, there was a theoretical risk of PCNL being dead, and one more time we have come up with section mini PCNL. So I'm pretty confident that PCNL is here to stay, and that is what is the evidence that this is the EAU guideline. And if you look at any kind of stone size, any stone location, or any scenario, PCNL always features in as one of the option for the management. What as a urologist would we like to have as an ideal stone procedure? It should have been efficacious, giving us maximum stone-free rates and at minimum morbidity. So this is what our quest is. Standard PCNL was giving us very good stone-free rates, but the problem were because of the morbidity, and most of the morbidity was related with the track size. And Rajesh Kukreja, my expert, is here. He has published a fantastic paper on this. So this is how the track size in PCNL evolved. It started with 54 in 40 French, then 30, then the mini PCNL 15 to 18 French. Then Janak Desai gave us 13 French, and MRD sir gave us 4.8 French. So this is the evolution coming from the larger track to miniaturization. And these are the terminologies used to describe various track size. And for this talk, I'll restrict myself to talk about mini PCNL, which is 14 to 20 French. So when we were trying to see now whether we have achieved a balance between stone-free rates as an efficacy and the safety parameters, we thought wonder has happened with mini PCNL, but we were wrong, because mini PCNL came with so many problems. It actually gave us inferior stone-free rates, higher infectious complications, longer operative time because there was poor vision and fragment migration. All of these things were happening, especially when we tried to use mini PCNL in a larger burden stone or a complex renal stones. So, friend, one of the major thought, which we need to start thinking about in PCNL as well. We keep on talking about this in RIRS, but this is, as Sabnis had told, equally relevant even in PCNL when we talk about the miniaturized versions of PCNL. And as stated in the earlier talk, that IRP needs to be always looked at, and we need to be making sure that we always have a control on that, because once we go at persistently more than 30 to 40 millimeter of mercury, there are incidents of sepsis and death. And if I can recollect from one of the slides of earlier presenter, the meta-analysis showed that there was 0.1% death, in out of that's out of every 1,000 patients of URS or RRS. If you explain a patient, there is a risk of 0.1% of you being dying. That is quite serious. So, friend, there came the game changer, suction, and suction brought a lot of value in the endourology. Now, there can be two mechanisms of suctions. One is the passive and one is the active. Let's talk about the passive mechanism. This is actually as per the Bernoulli's principle. We can call it as a vacuum cleaner effect. We can call it as a Venturi effect or eddies current. This is what Jackman has given us. That he gave us a 15 French sheet which was designed by Nagel
and there was 12 French mini nephroscope. So there was 3 French difference between these two things. The idea was to get a rounded shape internal end and a trumpet shape at the external end. Because of this kind of shapes, the fragments used to get entrapped in a low pressure bubble, which was created because of the differential pressure gradient. And when we withdrew the scope, with that bubble, all the fragments could be sucked out. And when we get out of the trumpet end, we can drop down those fragments and achieve the clearance. So this was the vacuum cleaner effect or the Nagel's effect, which helped us in Mini-PCNL before the active section came into role. However, the active section, it can be either in combination with energy devices. These are all the devices you all are familiar with, Cybervan, Shock Pulse, or Trilogy, but these are all compatible only with larger PCNL, standard PCNL. So I'm not going to talk about this because they are not compatible with miniature agent versions. But there was one such device which was produced by EMS, and that was a laser section device wherein there was a sheath which housing laser sheath, and then surrounding there was a hollow probe through which a suction can be activated, and this could go through the mini nephroscope. And Abhishek has done a study of around 200 patients. It was a retrospective analysis, and they found all the advantages: higher stone free rates, lower infectious complications, and shorter operative time. Though I don't know why this device never got popularized. Anyway, now the more popular ways of doing active section in PCNL is to specifically design sheaths. And it will be unfair on my part if I don't give due credit to Dr. Kaushik Shah, who invented this in 2013, 2014. So he came with all this called a super bug section sheath, which came around in different sizes. And this is the setup. There are 4 sizes of the sheath: 12, 15, 18, and 21. And we can use our own mini nephroscope, which is 12 French. And this is the connector. On one side, there is a pinch valve Kwok action, wherein we can activate the suction. On the other side, there is a suction attachment. And this is the complete assembly. So this is the universal kind of suction sheath with scope assembly that most of the Indian urologists are using currently in their practicing. So this is the attachment. The suction pipe, which is yellow colored, is attached to that connector, and it is taking that thing into the container bottle wherein all the dust is getting connected. On the other side, the tube goes to our own OT section. So this is the standard kind of super puck suction sheath attachment. And if you see, the pinch Kwok action can be used versatilely, so that not just the constant suction can take out the dust, but even those fragments can also be aspirated by withdrawing the scope. So this is what is that we can actually enhance that Venturi effect, and by keeping that pinch Kwok action occluded intermittently, we can take these fragments out, and it can add value to that passive and active section in combination. So this is how it can be done, and we can take out a lot of the fragments, and we can avoid the too many uses of forceps into that. And this was the first study, to my knowledge, which was published on suction sheath Mini-PCNL in the IJU in 2017. It was a prospective study of 52 patients, fantastic stone-free rates. The mean operative time was 42 minutes, and average hospital stay was hardly 1.5 to 2 days. The one more popular kind of sheath which has been used more in the Western countries is Cleopatra vacuum assisted suction sheath. The concept is basically same as Shah sheath, but it's more popular. It's marketed very well. A recent publication demands study that it was published just in January 2026. It was 10 RCTs. They looked at 1540 patients. The improvement in the stone free rate was 23.7%. The mean IRP was reduced by 8.25 millimeter of mercury. There was 41% reduction in post-operative fever, and operative time was reduced by 13.86 minutes. So these were 10 randomized controls data pulled, and every single parameter was favoring suction as a valuable adjunct in Mini-PCNL. So friends, these are all the advantages. It gives us better vision. There is less retropulsion and continuous removal of stone fragments. There is reduction in IRP. Automatically, there is reduced infection complications. The operative time goes down. However, there are few disadvantages. It can add to the equipment cost. There is a learning curve. There are some complications. I'm sure Rahul is going to talk about it after me. And at times, there can be equipment malfunction. But my take-home message regarding this is that suction Mini-PCNL is definitely an integral part of the modern endourology techniques that maintains low intraanal pressure, improves vision, reduces the infectious complication, enhances surgical efficacy, And it's especially relevant in case of complex, high volume and stegon stone, because these are the stone wherein the stone fill rate without section of mini PCNL are quite inferior as compared to standard PCNL, especially in pediatric population, infection stones, and miniaturized versions of mini PCNLs. Friends, there are certain future things yet to be done. We need a direct head-to-head trials of different suction apparatus, and we need to do a cost-effective analysis. The long-term outcomes are yet to become, and we need smart suction systems depending on the AI, where we can have not just real-time monitoring, but also automated modulation. So once this thing happen, I think we will achieve the trifecta of complete clearance. So friends, evolution is a journey. Nobody stops evolving, and the journey continues. But mind well, it is not just the machine or the technique. It is the man or the technician behind the machine that makes all the difference. And whenever we treat a stone patient, I always end up saying that always look at the patient and tell yourself, you are the stone, you are the chisel, you only are the sculptor. So offer whatever is best in your hands, within your expertise and within your armamentarium to your patients. Thank you so much for patient listening. Thank you, Abhay.
Thank you, Rohit. Your expert comments, Rajesh.
Yeah, am I audible, Abhay?
Yes, very well.
Yeah, so thank you, Abhay. Thank you to the USI and the Indian School of Urology for involving me in this excellent webinar. Rohit, excellent talk and must compliment you. You have covered all the aspects of suction and mini PCNL. Now, only two my clarifications would be one is first point you pointed out is regarding the intrarenal pressure. So it has been very well documented by many studies that as long as your sheath size is 15 French or more than 15 French, the intrarenal pressure is never a matter of concern. The threshold that is 20 millimeters of mercury or peak of 30 is never reached with a sheath of 15 or more than 15. It is only when you go to that ultra mini perk or mini perk excess that the pressure may rise. So when we are talking about mini PCNL, so pressure is not a matter of concern that you need a suction to reduce the pressure as you need in the RIRS when you use a suction to reduce the intrarenal pressures in a flexible ureteroscopy. That is point number one. Point number two, we need to have well documented randomized multicentric trials to see the efficacy. If you see a recent publication just around 2 months back in the European Focus by Vineet Gohar, and which was a multicentric prospective data collected, which I was also a member of that. And again, where he showed that it's only a slight benefit in the OR time that the suction PCNL had to offer as compared to non-suction. The stone clearance rate, the complication rates, everything was just the same in both the groups. So besides a very minor reduction in the OR time, there was not much of a difference. So if you see the actual mini perk sheet, which has a trumpet-like opening on the outside and which uses the vacuum cleaner effect, that actually serves as a natural suction and withdraws all the fragments without using a active suction. Active suction means you may sometimes cause oozing from the mucosa, and these are all concerns. So it's a good tool to have, definitely, and a clinician must use what suits him the best. But we need more trials to see if really suction in mini PCNL has anything advantage to offer over a regular mini PCNL, because PCNL is different than RIRS. RIRS, you're working in a closed space and you need suction to reduce the pressures and retrieve the fragments. In mini PCNL, neither is the pressure a concern, and fragments, of course, are coming out by the sheath itself. So that's what I want to say. Thank you very much, Rohit. Excellent presentation. Thank you, Abhay, for the opportunity.
Yeah, excellent comments. Thank you, Rohit. Thank you, Rajesh. So we move on to the next talk, which is in continuation with the suction mini PCNL, and that is by Dr. Rahul Gupta, and he's going to tell us what are the complications of suction in PCNL. Rahul is associate professor at the GMC Jammu. So over to you, Rahul, and the expert is Ravi Jain. Ravi.
Thank you at the outset, USI, ISU, my dear friend Abhay, Vishwajeet, and Keshav sir to have me here. I think my job has been made very easy after Dr. Rajesh, what he summarized. And if you really want me to expand on it, I'll expand on it. But otherwise, what Dr. He concluded, Dr. Kukreja concluded is what I'm going to take further. My slides are not moving. Should I share again?
Yeah.
Rahul, yeah. Share it one more time, it will happen here. Same thing happened with me. Come on.
Sure. There I go. And
Need to
Is it coming now?
optimize as well if required.
Sorry, come again.
Need to optimize as well.
Yeah, now it is moving. Okay, so I don't have any conflict of interest, and as I'll be talking about a few sheets here. The concept of suction, as Rohit adequately said, it is might reduce the overall procedure time, as Dr. Rajesh Kukreja also said, and all of the surgeons have that itch to, they feel that they're a better surgeon if they're able to complete their job faster. It is there, it is inherent in every surgeon. Reduce the intrarenal pressure, a lot has been discussed, and Dr. Rajesh has adequately put that facilitates decrease in the rate of infection. That is why the intrarenal pressure is talked about a lot, and bleeding related complications are also low if there is an intrarenal pressure is low. It gives a better stone-free rates with the suction. That's a questionable thing. Let's see what the literature says. In all, it gives a shorter hospitalization and a faster recovery to the patient. That is always an advantage. But everybody's talking about a suction in 2026. I just when I was looking for the things, I just saw the things, and I wondered. It is not a new concept. It is a concept which came in mid 1990s with the introduction of lithoclast master, which a lot of us have used, and it was a combination of an ultrasonic and a blastic lithoclast along with suction via the lithotripsy, which facilitated in the simultaneous fragmentation and the suction of the stone clearance. And it was a big, huge thing which was introduced, and a lot of surgeons started using it, but cost was always a factor in that. And that is why it didn't become very popular. But then came the era of miniaturization, in which Mini-PCNL, Ultra Mini-PCNL, etc., came in. High power lasers changed the way we do PCNL, because now from fragmentation, we were talking about dusting of the stone, and new suction integrated sheets have come up. The laser suction handpiece, which is not popular, even I am really surprised why it is not so. And the suction compatible nephroscopes have also come, which can facilitate the suction. So suction is going to be there, but there are going to be a few things I'm going to talk about. It is not without complications. It is not that if you use a suction and there is not going to be any complications. If not used judiciously, it can inculcate a false sense of safety in you. Because whenever you talk of suction and stone, it is basically you are extrapolating the RIRS picture into the PCNL, which is not the case always. So it is not as rosy if you use suction and everything is going to be good. A lot of things are missed. You have a rose and there is a lot of things around it. So a lot of things are not discussed when the company people, or when you go to a bigger conferences and you see about suction, what is happening. And I'm going to take and talk about these thorns in the suction. When we just put aside the rose, the beautiful rose, now you see what can happen. Tissue safety. There is always a risk of mucosal injury, the suction lesions. Visibility, a pelvic collapse is a disaster if you are using a laser in a PCNL. Economics, in a country like India, economics do matter. We have seen a fantastic talk before the colleagues which have given a talk, the fancy instruments we have seen, but we have to ask ourselves, can we really afford that? Technically, frequent clogging with the larger stone dust clusters, your assistant should be very well trained and know what you're doing. Physiology, potentially a rapid core temperature drop can happen if you are using the suction in a true way as it has been proposed to use. So it's not about the rose, it's about the thorns around the rose you should be very aware of. So what is a fluid and thermal imbalance? A hypothermic risk is a valid risk. It's a heat sink effect that can happen if the amount of the fluid which is going in and coming out is not at the body temperature. And coming from a cold area of Jammu, I can tell you in cold, it really becomes very cold. And if the fluid is not warmed properly, so it can act as a disaster. The fluid absorption, there is an imbalance when the suction is blocked. So again, coming to the assistant, if your assistant is not intelligent enough to tell you, or if you are not, you are just doing your stone and you are just immersed in your PCNL and appreciating your PCNL and not looking at the suction, what is happening there. So again, it can be a disaster for you, and a lot of fluid can get absorbed. And we all know in endourology what fluid absorption can do to you, and PCNL is no exception to that. Physical tissue trauma, a mucosal grabbing can happen, a sucking effect can happen, like what Dr. Chandra said, that it can happen in a pediatric cases if you do suction in RIRS. Similar things can happen if you are using a Mini-PCNL in a pediatric case, or a patient who has a very flabby sort of a kidney. And if you do a suction, everything will come into the suction and cause a trauma, which you don't want to have. a bleeding masking can happen. So this is a very rare event in PCNL. If you're not using a suction, you're aware about the blood which is falling on the ground, in the bucket, your assistant and everybody sees. And even if you're not noting that, they can point out, boss, a lot of blood is coming out. But if you're using a suction and everything which is bleeding is going into the, the suction tubing and things like that, sometimes you can just miss that and you can end up in a disaster. Equipment and technical hurdles are definitely there. A small diameter suction sheaths are always small. They're not very big. So, they can get clogged very easily. The vacuum effect can happen. If the suction is too strong, it can collapse the renal pelvis, as I said. And it is difficult to maintain a clear visual field, which we often see, especially in case of a supine PCNL. It becomes very difficult to use a suction in a supine PCNL. Loss of small fragments. This can happen because you're pushing a lot of fluid from below. When you're pushing a lot of fluid from below and you're not using a laser and not dusting, you're fragmenting. A lot of times a simple pelvic stone, you can end up having a multiple stones in all the calyces. Believe me, if you're using a lot of pushing, fluid is getting pushed from below, and you will be surprised that at the end of the C-arm picture, you see that a lot of stones are here and there, they don't make you feel happy because you're not able to clear on the one go. If the system is not properly primed, there is a probability of air going into the PCS and into the blood, and that can be disastrous for the patient. Cost and complexity, it's always there. These are the three types of sheets. Two have already been discussed. And this is the lependopod, which I innovated for myself. I use it for laparoscopy and, the suction PCNL. The learning curve is always there for a suction PCNL. It is not like that one day, one fine morning, you will be expert in that. You always know when you want to give the suction, you want to do more of irrigation, and with the laser, with the lithotripsy, they are two very different energy modalities, and both have a different learning curve altogether. This is the first time, this was not 2009, when the Chinese PCNL got very popularized. This is the machine they have been using. And if you look at this machine, it's the pressure up to 300 millimeters of mercury for about 3 seconds. Then there was a stop of 2 seconds and then a repeat of cycle. So it had to be a coordinated event. It is not like that you put a suction here and irrigation from below and you will get a good, the ideal way of doing a suction PCNL. That is not the ideal way. That is, to me, it looks like more of a jugadu way. But in Indian scenario also, we have a Nidhi pump and a pump which is introduced from my own institute, which is MTUH, and they have a pressure pump in which the tubing is attached to the system. And if these pumps are very essential because there will not be effective suction without good irrigation. If you don't have a good irrigation, there will be no suction. So you have to have a fluid to be get sucked, and with the fluid, the dust and the particles and everything will come out. So now let me give you a reality check. This is a questionnaire I put up in my alma mater, and I'm really thankful to all those who have helped me in filling up this questionnaire about Mini-PCNL. Look how many of us are in reality using suction. There were only 23%, and I can vouch for it. Anybody who has been trained in MPUH will do a good PCNL for sure. With Sabnis sir heading the things, and with MRD there for his blessings, everybody is doing a PCNL. So how many of us are using a suction? Is 23%. Use laser. Not everybody has an access to laser. Suction, I believe laser is a modality of choice because it does and makes very small fragments vis-a-vis lithotripsy, in which suction may not be as effective. Dedicated suction for PCNL. Nobody has a dedicated suction. It is a OT suction which everybody is using, and which Rohit also showed, and which whose suction power is very, very different, as we all know. And retrograde irrigation is mechanically. Nobody is using it mechanically as was proposed in the Chinese initial PCNL. So everybody is doing manually. So when you do it manually, you may not get the ideal effect of a suction PCNL as you want or as has been propagated in the West for this thing. Now, let me give you a reality check of the publications. So if you look at these publications, there is only 2 papers which have said that they get 100% clearance. One is Goke in 2021 and one Dr. Shah in 2021. And if you look at that, the time frame in which they have gone and got a complete clearances up to CT scan after 48 hours and 1 month after the surgery. So when you're doing a suction PCNL, it is the results are almost comparable to RIRS. So if you are using a suction PCNL with the hope that you will get 100% clearance, I would be really skeptical. Look at these clearance rates: 93, 80%, 87%, and 90%. And the type of sheets you have used is from 16 to 20 French, as we all know in the Mini-PCNL. So to propagate that use of a suction will give you 100% stone clearance on the day one is a myth. So you can use suction, it has its own advantages, but don't go with that fixed frame of mind that you are using a suction and it will give you 100% clearance. That is not going to be the case. Now, see this paper in 2024, what they have said. the suction techniques appear to improve PCNL outcomes, but the quality and quantity of evidence are still weak and no definitive conclusion can be made. So this, this facade of a suction is the panacea for everything, is not yet established even in the present time. Now, this is a paper in which we have a lot of endourologists from India. Even our president is also there. Abhay Mahajan is also there, and a lot of good people are there. They have used for a stone size of 1700 millimeters cube. A single access is 92% of the cases. They have used TFL laser in majority of the cases. Stone clearance raised at 82%. And the re-intervention was performed in 2.6% of the cases. So again, if you're using a suction with the aim that it's panacea, it's not like that. So it's not a foolproof method to attain 100% instant clearance. So you should go with that frame of mind. So does it have its own complication, blood transfusion rates? Yes, it is as good as any other thing. And sepsis, it is not that if you use a suction, the patient will not get sepsis. It is not like that. So to conclude, to take home message from my side would be that suction in PCNL is not a one-stop shop. It is not that if you add suction to your PCNL, mini PCNL, you will get away with everything and anything. So it will not guarantee a complete clearance and sepsis-free procedure if you overlook the basic principles of mini PCNL. You cannot overlook the principles of mini PCNL. So be aware while using the suction in PCNL. It can reduce the visualization, so it has a learning curve. Systemic collapse, mucosal injury and bleeding are a definitive risk, can cause intra and extraposition of the fluid if that happens. Beware of that. Fragment migration is a reality, especially if you are pushing a lot of fluid from below and not using a laser or dusting. If you're using fragmentation, fragments will fly here and there. Pressure control issues are there. Those thermal imbalances can happen. These are the complications of use of suction. Increased costs, so need to be justified, whether you can really afford or your patients can really afford that. And in the end, use suction judiciously and don't follow blindly, as it is not without complications. Thank you very much. Thank you, Abhay, and thank you, Dr. Vishwajeet, for having me. Any questions? You're welcome.
Thank you. Thank you, Rahul. Nice
Yes,
talk. You have put up a lot of controversial points to be discussed, and we'll hear something from our expert Ravi, what
Yes,
he
sir.
has to say.
Excellent talk, Abhay Mahajan, sir. First of all, thank you for inviting all the esteemed faculties and having so much of doubt and debate about suction in endourology. And all that glitters is not gold, and suction, maybe it in RIRS, maybe it in PCNL, has a positive side and a negative side. Well summarized points by Rohit Joshi sir, summarized by Rajesh Kukreja sir, and now by Dr. Rahul Gupta. One point I would like to add to the advantages of suction in PCNL is that it also decreases the use of forceps. You don't need to keep removing the fragments, and it decreases the wear and tear of the instrument. It decreases it improves the ergonomics, and it decreases the fatigue of the surgeon. Now, two questions to Rahul sir and Rohit sir both. Sir, please define the pressures of the suction, because this point is most of the times missed. Like, what should be the suction pressure? Because this will be the actual thing which can guide that what suction pressure you need to have, number one, and what irrigation flow. Especially Rahul sir was talking that pushing the fluid from below. I don't think that during PCNL after the puncture you need to keep pushing the fluid from the retrograde catheter. So please enlighten on the suction pressure. Rahul sir, you are mute.
Yeah, Rohit, you want to go first?
First of all, Abhay, I never thought this was a debate for and against suction in PCNL. I thought
No. It is not a debate. I'm just
kidding.
I am not a debate. I cannot debate with you.
I'm just kidding. I thought you are going to speak on this complication of suction. Anyway, so yeah, Ravi, see, the two things even Rajesh told that, you can, or Rahul told that we cannot use the suction machine which are there. No, you need to calibrate the machines, and the set limit is 0 to minus 100 kilopascal. So that is the pressure we have to calibrate. So we can never, turn down then. Secondly, see, whenever you are using a very miniaturized, for example, I just wrote it down, 7.5 French micro per in pediatric population with 12 French sheath, at that point of time, at times you need to put some retrograde saline installation, and as well as the flow has to be at least 130 ml per minute. Which is, otherwise, if you're not using suction, that can be 100 and 110 ml per minute. But otherwise, you need to have 130 ml per minute. That's what my take is on that.
So now, up to minus 100 is the cutoff.
Is cut off, yeah.
Yes. And anything for the irrigation pressure, irrigation flow?
That's what I've told. 130 ml per minute. See, otherwise non-suction we can get away with 110 ml per minute. But this is at least you have to, because whenever you're employing suction, your inflow rate has to be higher.
Okay, Rahul sir.
No, I'll just take it again for that. The problem is that when this suction and this thing came up with this thing is that if there is no fluid in the PCS, you cannot suck anything. If you're putting the suction on and there's no fluid in the PCS, it will not do the suction. So you need to manually push the fluid from below to have some fluid in this thing, and which have a retrograde effect. And when you are sucking and everything comes, the dust comes out with this thing. The issue with the at present for the suction PCNL is what issue I'm going to discuss is the use of the suction machine. Now, as Rohit is pointing and he showed that the suction, I am also using the same suction machine, but is it the ideal suction machine? I will not agree with that, because all PCS are different. If you do a PCNL on a regular basis, it's a very different, every PCS is different. So you cannot have a set limit of this thing. You cannot have a set limit that this is the pressure I want to use. And I have seen one of the endourologists using a neonate suction. The neonate suction is a very low power suction. The neonate, if you go to the NICU, they have a suction machine, which is a very low power suction. Now, what power has to be used is within question marks. So what gives you a clear vision is the suction you want to use. And the problem at present is we don't have an extra machine to invest and put it there, and that is not calibrated yet.
Okay.
So we have to use the machine.
Rahul, point well taken. So we move on. I think there's no pressure which has been defined at in various publications. There are two comments from Vikas and Ganesh Kamath that there is a limited role of suction in PCNL. That is what they feel might increase complications, and there is no major benefit from suction in PCNL. So I think nice discussion.
Thank you very much.
We have to move on to the next speaker. So I welcome Dr. Takaki Inoue from Japan, and he is going to speak on suction ECIRS. So welcome, Dr. Takaki. I'll shortly introduce Dr. Takaki. He is at present visiting professor at Department of Urology, Kobe University. He's treasurer of Asian Urological Society of Endoluminal Technology and is also faculty of Asian Urological Surgery and Training Group. He has a lot of awards to his credit, and he has more than about 100 publications, and he is a fan of ECRS. So I welcome Dr. Takaki. The expert will be Karthikeyan. So you can start your talk and start sharing your screen. Thank you.
Okay, so thank you for the kind introductions. So again, thank you for your late invitation to the USI ISU, maybe section of March 2026. So good evening at the night timing. So my topic is suction, minimum invasive issues procedures with US mandatory guidance and supine positions. Okay, so currently, maybe transition of renal cyst in a PCNL has been changes. So from the bigger success size, like maybe minimum tract. So usually nowadays, one of the trend to use the minimal patient tract less than 20 French meters. And also the maybe development is faster. Nowadays, suction technologies emerge in our some patient procedures. I mean, being smaller tract, of course, when using the suction sheets, maybe being clearer surgical field. This is one of the trend. How about how to operation of the kidney stones? So of course, maybe how to operate the kidney stone has been changing gradually. So usually maybe we use maybe over 24 French metal tract sheets and the standard conventional patient procedures from positions. Nowadays, of course, maybe we can use the Mini-PCNL and from position and the supine position like this. And also maybe a section with section technology is coming up. That's why maybe we use the section Mini-PCNL. So because but nowadays it's one of the trend like using mini intra combined in a surgery. So maybe it has been get popular and popular around the world nowadays. Being smaller accessories, tracts with sections. So now, therefore, maybe we have some concern. What is the clinical outcome results when we doing maybe a mini issue procedures with sections? So one of the randomized trials. So maybe comparisons between the Mini-PCNL versus mini-issues in personal plaque stones. So maybe with 67 participants. So compared maybe the both mini-PCNL issuer procedures. So maybe the advantage in so mini-issuer procedures have there maybe initial stone-free. I mean only one sting surgery. So mini-issuer procedure is superior, was a superior stone-free rate. So to the maybe usual mini-PCN procedures. However, the complications, so maybe totally, so between the mini-PCNL, mini-issuer procedure, there is no benefit, almost same equivalent rate. So postoperative fever and the sepsis, almost the same. But the problem, one of the concern is one of the concern is the operator time is a little bit longer. So when doing the mini-issues procedures, so maybe compared with the mini-PCN procedures. Again, nowadays, maybe a suction technology has been so emerging in our urolithiasis treatments, especially PCNL, of course, including fans. Fans sections is one of the key game changers. But of course, when doing a PCNL, when doing the issues procedures, suction technology is also one of the game changer, I think. So maybe how is the sections mini-issue procedures compared to the mini-issues procedure section? So this is one of the point of view. So what are benefits of suction mini-issues procedures? So first is a much clear surgical view, of course. Of course, when I doing the issues, maybe usually my position is under supine. So and second is lower internal pressures. We can adjust maybe optimal, so maybe surgical visions. Of course, this surgical visions keeps by our subjective findings. Third is flexible URS. This is very good advantage. Flexible URS assisted to the unreachable renal calyx from the maybe percutaneous tract. And less multiple renal tract, thanks for the flexible URS assistance. And then less complication rate, especially bleeding, especially maybe less radiation exposures. Of course, maybe the patients or medical staff, operator, surgeon. And of course, higher complete stone full rate. So of course, without maybe multi-renal tract. So possibly one month after operations. So maybe CT scan revealed maybe complete stone full rate is a little bit higher. First, second. So maybe to keep a clear surgical vision view and lower renal pressures, it is possible to adjust. So maybe we can control the balance. I mean, high ligation sections, but key is a surgical view because we cannot calculate nowadays intrarenal pressure real times. Therefore, the surgeons need to keep maybe distinction of renal quality systems. This is a subjective findings. So especially maybe assisted the flexible URS. Flexible URS go into renal correction systems and also go into the PCNL side, go into renal correction systems. At some times, irrigation pressure has been going up. This is very, very careful moment. Therefore, maybe I think retrograde operators, antegrade operators communicates more and more, right? So in one operation, this is very important. It's a very difference. So between the usual PCNL or usual mini-PCNL procedures. Communication is one of the keys when doing the mini-issue procedures, I guess. Especially maybe clear surgical view and lowering the pressures. So when doing the cystine, so inherited stone like a cystine or uric acid stones, usually sometimes maybe this integration of the cystine, so uric acid stone is generated multiple white bubble or maybe a white snow. So white snow and white bubble is hesitated our clear visualization intraoperatively. That's why sections, especially with high elevations, can be very, very helpful. So to be clear surgical view, this is one of the best options, especially maybe cystine stones, I think. So maybe most important advantage is like this. Flexible rotoscope assisted to the unreachable calyx, renal calyx from the maybe percutaneous tract. This means maybe we can be restless multiple renal tract, I guess. Usually, when doing the usual patient procedures, the patient tract so cannot access in the different calyx, like anterior upper calyx, anterior lower calyx. At some times, usually we need the additional renal tract again. I mean the multiple tract. Multiple tract means that much bleeding happens sometimes. I mean the complication rate is higher. Staying hospitalization is a little bit longer. This is not so good for the patient, of course. That's why, so maybe easier procedures, most important things, this is a big benefit, I guess. So if the targeted approach, I mean, the patient side cannot so reach the lower pole and upper pole, so middle pole, so flexible RIRS can assist to reach, so maybe unleachable renal calyx. And then, so of course, stone size a little bit smaller, so flexible RIRS maybe can use the basket to maybe replace. So from, say for example, from the upper pole to the middle pole, this is very, very helpful. One of the big benefits when we doing the patient procedure, when doing ischias procedures. This is one of the possible technique. Same way. So even though port access so is very, very how can I say effective to remove the old stone fragment, especially stagnant stones. But so usually we access maybe inferior part, upper pole, middle pole, and lower pole. At that times, if the some stone is parallel, I mean along the linear tract, so sometimes anteriors, so maybe linear calyx stones are located. At that times, it's a very difficult to access. So maybe a front percutaneous approach. At that time, some flexible URA assisted. So to replace the anterior calyx to the ventral calyx, there is no additional, so much additional linear tract. This is one of the big benefit for the patients. Like same way. So anterior axis cannot reach the parallel stones. Parallel stone is, I mean, stone is the anterior part. So flexible URA assist to replacement of the stone fragments. And there's a less complication rate. So especially a less radiation exposure is is possible to reduce. So when we use so maybe ischial endoscopic combined linear research, both approach, flexible side so can reach so target calyx for the linear punctures. So maybe a flexible side can watch the whole process of needle punctures and tract dilation under direct vision, so intraoperatively. Of course, we can check, so maybe after bleeding degrees, so under the direct vision of flexible URS. It is very, very very good advantage to keep the safety for the patient in our operations. And of course, maybe a totally achieved, so maybe less radiation exposures. So therefore, I think ischias procedures, especially mini ischias procedures, suction ischias procedures, so is one of the big benefit. So this case is so maybe we had arterial bleeding. So when I punctured one times, so flexible side, I mean lateral side. So maybe check the linear bleeding like this. So small arterial bleeding happened, but flexible URS found the bleeding so degree. At that times, we can stop further linear dilation. So this is one of the way. So to be less complication, especially to be less bleeding, it's one of the good benefit. So maybe when doing the ischial procedures, I guess. And there's a rather higher complete stone free. So I mean, nowadays maybe when we so may break the stones, usually we use the laser. Laser, so disintegration is getting the common. So because maybe a laser disintegration is have a lot of versatility. So, but sometimes almost maybe operations. So there is some tiny fragments. So there is some tiny dust left, especially in upper linear tract, I guess. At such times, flexible can reach upper linear tract and maybe middle renal tract, and a little bit flush the cell line, and then so simultaneously push the band of flexible patient side. So maybe with the suction device technologies, so we can at that time we can remove so all stone small fragments and all stone tiny dust completely. So this is one of the good way. So maybe when using a suction issues procedures, yes. Again, so what a benefit of suction to issue procedures, much clearer surgical views, so and lower internal pressures. But problem is we can so maybe control that. So good surgical view and the surgical internal pressures by subjective findings. So this is very one of the good way. And of course, flexible assist leachable calyx, less linear multiple linear tract, less complication, especially less radiation exposures. So before the end of my so maybe surgery presentations, so maybe I want to show the one case is that so bigger so linear stones. So usually maybe when I doing the issue procedures, maybe we choose the maybe a supine position like this. So and then of course maybe we use the combined fluoroscope and the ultrasound axis, but mostly so ultrasound axis is very important. So maybe all step, so flex BRS, so check. So maybe a linear tract and so linear tract dilations. So from a retrograde view, under light visions, this is very important point. Nowadays, maybe we use the Cleopatra, so 15 to 16, and then 12 miniaturized nephroscope. Again, so maybe communications in each side, retrograde, antegrade is very, very important. So of course, maybe in suction issues procedures, a lot of advantage here. But we don't forget that, of course, disadvantage is there. So maybe we need more cost, we need more monitors, equipments, and we need more surgeons, number of surgeons. And then so maybe we need more communication with each operators of each staffs. Thank you for attention.
Thank you, Takaki, for your nice presentation. Over to Karthikeyan for one expert comment.
Hope I am audible. Thank you, Dr. Takaki. It's a nice presentation. Despite this well past 12 in Japan, thanks for joining with us. I have few concerns and comments about having suction in ECRS. Suction in RIRS is well established and more popular, and the benefits are well visible after the introduction of fans. But it is not as such with PCNL, especially when we have a ECRS where we have combined RIRS with PCNL. It is as such is a low pressure system because of the open end from the PCN side. So having a suction in ECRS, we don't know how far it's going to help. And especially mini ECRS, when you have a tract less than 15 French, having a suction may be helpful. But doing a RIRS simply is different from doing RIRS along with ECRS. We need to close the PCN system at times to make the PCS open so that we have a better vision during RIRS. If we have a suction during ECRS, it is going to be difficult for the RIRS surgeon. I know it's technically feasible to have a suction in ECRS, but whether this suction in ECRS is going to be beneficial in terms of safety and efficacy, only time can tell. We need more RCT to compare ECRS without suction and ECRS with suction. Thank you.
Thank you,
I agree. I totally agree. Yes.
Yes, thank you, Takaki. Nice talk. Thank you, Karthikeyan, for the comment. So we move on to the last topic by Dr. Parimal Gharia on suction RIRS versus suction mini-PCL, a very precise topic and should be to the point. So Parimal from Surat and Sunirmal Chaudhary is the expert for this talk. Parimal can avoid some repetitive slides if possible, if they are already taken up by all the other speakers.
Yes. Yeah. a very good debate or a difference of opinion for the suction in RIRS for the traditional suction versus the suction RIRS for the traditional PCNL versus suction mini PCNL. The mini PCNL has been a very good standardly established over the standard PCNL with the less hemoglobin drop, less blood transfusion, and less chance of post-surgery angioembolization, but at a cost of a longer operative time. And it has been established very well established things because the track is a smaller. But the important is the fluid dynamics. When we are doing a mini PCNL, the fluid dynamics is a whirlpool effect or a vacuum cleaner effect, and these may be important in an infected collecting systems. So the chances of a post-operative fever in a mini PCNL versus standard PCNL has been always be there, and this theoretical or maybe the practical risk, there is a suction PCNL has been established, and the super mini PCNL or the SARS sheath or the ultra mini PCNL, right, the suction in mini PCNL has tried to establish, and there is a whole spectrum of PCNL in this case. The suction PCNL versus mini PCNL, standard PCNL, we already know that the suction PCNL has some very good in a review or in a systemic review also. It has a superior outcomes, less operative time, and minimal the infectious complications, and it can be used for any cases. But the addiction of suction PCNL in the real world is close to 55%. Still 50% of urologists are not adapting a suction PCNL. And the largest study of the mini PCNL suction was established by the STUMP, and it has a given good operative time benefits and the decrease infective complications. The results of STUMP we all has to see. The suction in RIR has already been discussed in detail, and these are the different options for suction in PCNL. Now the real game changer is the discussion is between the stone with the fence versus PCNL. If in a study which had a more than 2.5 centimeter stone fence versus PCNL, it is a comparable stone-free rate on the both the sides. The mini-perk versus suction mini-perk with the suction and the suction RIRS subgroup analysis. It has been equal stone-free rate. Suction mini PCNL versus stress. The only study which has directly compared the suction mini PCNL versus the suction RIRS, including the fans, is the head-to-head study, and it was a combining two studies, STUMPS and the Flaxer studies, and the results are propensity match analysis, and under 686 patients were matched. The invasiveness of suction mini PCNL is more invasive. It is a puncture, risk of angioembolization, whereas RIRS is a less invasive, no puncture to the kidney, no potential damage to the surrounding organs like pleura and. So the first point in discussion between suction RIRS and the suction mini PCNL is the invasiveness of a PCNL versus a non-invasiveness or a minimal invasiveness of an RIRS. Second thing is an operative benefit. Here the suction mini PCNL scores better than the fans because it has a less operative time. The use of accessories, the fans is better than the mini PCNLs. Post-operative pain score is, as usual, we are not doing puncturing, so the pain score is, and the report of recovery is better with the RIRS with the suctions. Post-operative fever, you can see it's almost, there is no significant difference between a suction mini PCNL and the suction RIRS. The hospital stay is obviously less for the fans. But the biggest advantage or the one point where the mini PCNL scores over the RIRS or the fans is the possibility of the stantless procedures, where the fans is either it is a pre-stanted or is a post-stanted, but the stent requirement is a must. The different definition of the stone-free analysis for this 10 was the grade is 100% or a zero stone-free rate, and you can see that intraoperative stone-free rate was better with the suction mini PCNL versus the fans. The stone-free rate at the 30 days also here. The suction mini PCNL is a grade A stone-free rate was better with the mini PCNL compared to the fans. And we can see that if they have done a multivariate regression analysis for the factor, and the suction mini PCNL is the way to get a grade A stone-free status compared to the fans. And the main important thing is the guide stone score 2 or guide stone. So this the important in these cases where the stone gets complicated, mini PCNL works better than the fans. The limitations of this available data is what it was not a randomized control trial. It was a real world study with the heterogeneous group of stone characteristics. most centers and surgeons were common. So they were the experts in stumps, fans, mini-PCNLs, or the using of suction in RIRS as well as mini-PCNLs. But the views of the surgeons outside the study also may have a different take on the suctions. And the suctions in fans and suction in mini-PCNL is still in evolving phase, and adoption is far from routine and it's not standard of care. The key factors for making a decision for the stone or use of suction, non-suction, mini-PCNL versus fans or suction is the stone size, stone volume, stone complexity, stone location, anatomy of PCNL, and all other factors which it has been established for a very long period of time that these all factors make our decision making how to go for a suction mini-PCNL or a mini-PCNL or a PCNL or a fans. My 2 cents on this is vast experience and local expertise in PCNL still makes it a great choice in Indian context. The mini-PERC introduce increasing number of tubeless procedure, and that is the biggest advantage, and the hospital early discharge is from the hospital is early. And whenever we are doing an fans or we are considering the fans, the story of narrow Indian ureter should be considered because it makes the procedure 2-stage procedures, and we still don't know the exact long-term effects of ischemias on the ureter from the fans, and it need to be considered. So the take-home message from my side is for the standard PCNL is the fastest and the most effective way to clearance, but it carries a slightly higher break risk. It is based for the complex stagons and infective stones. ECRIS is a new emerging gold standard for the complex stone borders. Mini-PERC from medium to large stones and the less complex stones. Mini-PCNL, if the stone is more than 2 centimeter, suction maybe have a greater effect. It decreases the operative time. Stone less than 2 centimeter with infection, mini-PCNL with the suction can be considered. Otherwise, other all stones, the standard mini-PCNL was better. And RIRS and fans is superior safety profile, early return to work, and it is only for the low to medium size stone with a favorable anatomy, especially to medium and large size stone. And RIRS should be considered whenever there is an associated ureteric calculus. We are in an evolving phase of inflated expectation about the suction, and we need to think about the real safety of these suction devices in Indian context, and we need for that and our data and the RCTs for that. And I thanks Urological Society of India as well as ISU and Urolithiasis section for the presentation for the comparing the suction mini-PCNL versus suction RIRS. Thank you.
Thank you. Thank you,
Thank you,
Parimal.
Parimal. I have one comment, Parimal, that I think on Indian context, we have to individualize the case. It is not the SMPCL is not the fans, but we have to individualize because Indian ureters are narrow. So we have sometimes we have to choose the SMPCL more over the fans RIS. And what is your take on more than 3 centimeter stone? Some people are also using the fans RIS more than 3 centimeters. What is your take?
Sir, more than 3 centimeter stone, I think the best way to go for is this either a standard PCNL or a mini PCNL with or without suction. It's if you are comfortable using a suction, if you are well versed with the suction technology, then only you go for the suction. Otherwise, the standard PCNL works best for the large size of stones. We should not to push the limits of the stone because ultimately it's the operative time that decides the infective complication rather than anything else.
Yeah, excellent.
And another thing, just a minute.
Sunil, we have to stop. We are exceeding time.
Okay.
We are already 5 minutes away, so we'll discuss this later. Excellent talk by Parimal. Thank you, Sunirmal. And concluding remarks by Dr. Vishwajeet Singh, Secretary of the Urolithiasis section.
Dr. Abhay, you can take few questions if there are some questions from the.
There are no questions actually. I'll just go through. Yeah, there's one question from Dr. Ganesh Kamat to Dr. Takaki that the title of your presentation referred to use of ultrasound Doppler. Can you elucidate further? So, Dr. Takaki, are you there for this question?
Yes, thank you for the questions. Maybe I will use maybe Doppler, especially enabled by the Wandler Doppler, color Doppler like this. It's a very, very effective to be less bleeding. I mean, so with the linear parenchymers, of course, maybe some of the big artery lining, and therefore maybe when using Doppler ultrasound mode, so we can avoid maybe injured or maybe linear renal artery. This is very, very effective for me. In my maybe daily ablation PCNL procedures, you can definitely use the ultrasound and the ultrasound guidance.
Yeah. Takaki, there is one more question from Dr. Vikas. He's asking, have you tried fans in prone ECIRRs?
Yes, of course, definitely. But so prone section issue procedure is not so good, especially in flexible rest handling a little bit difficult. So, of course, maybe surgeon assistants is getting used to the maybe flexible in prone positions. But I think younger residents, younger colleagues cannot pray very well. That's why. So at least my daily operation usually maybe I use the. I use the pro with maybe supine positions.
Supine. Yeah. Thank you.
Yeah.
Thank you, Takaki. Thank you. So there are no questions, Dr. Surya Prakash. We can move to the concluding remarks by Dr. Vishwajeet.
Yes.
Dr. Abhay, can I ask one question? I know it is going late.
Yes.
No problem. Please,
So
please.
maybe I have missed that data that everybody is talking, and maybe everybody is right that the sepsis rate is less if we maintain the less internal pressure and if we monitor the pressure. But how less is the less? What is the clinical impact?
You mean there's a suction issues procedure?
Whatever it is, wherever we use the suction or we manage the internal pressure less, the chances of sepsis is less. My question is, how much less is the less?
So I think Dr. Takaki and Dr. Kwok, Jia-Lun, you can answer this question also, because this is pertaining to your talk.
So I think there's
maybe Steffi had presented first talk on internal pressure.
Yes,
and
Steffi.
he was talking about the sepsis rate. So how low is the sepsis rate if you use this? Because why I'm asking the question, whenever you add some armamentarium, there is a cost is the issue. And if you have to see the cost benefit ratio, that's why I'm asking this.
Mm-hmm.
Yeah, Kwok, you can go ahead, and then Steffi can join later on.
No, I think if you review the literature currently right now with fans and suction, actually the sepsis rates are quite low. But I think the initial studies were on normal anatomy. So I think if you go to the abnormal anatomy, then you need to reevaluate that. But I think generally the evidence for sepsis is actually quite promising, that the infection rates are much lower. I think there's recently another paper that shows in terms of sepsis rates in infected urine is actually very low as well. So I think definitely suction has added that dimension to decrease infections.
Yeah, Steffi, your views?
Yeah.
I think Steffi is not there. So Takaki, have to comment?
Yes. So maybe how is the later lower later sepsis? So there is no evidence maybe when using a suction issues procedure, I guess. So only one survey so in Japan. So maybe usually maybe sepsis rate. So maybe after suction issues procedure around less than 2%. This is not higher or high. I don't know. I'm not sure. But the problem is so especially prone issues procedures, both approach from laterally and anterolaterally. Sometimes maybe be careful because to be higher interpressure dramatically, right? That was maybe we need to communicate with each other. So of course maybe especially prone position is compared with the prone position, it is supine positions when using a suction issues procedures. Prone position is get higher sepsis rate. This is one of the evidence. Therefore, we have to be careful.
Thank you. So if there are no other questions, then should we move on?
Yes, please. Yes.
Yeah, Vishwajeet.
Yes, thank you, sir. Respected President Dr. Keshavmurthy, sir. Secretary Dr. Uttam Mehta, sir. Chair ISU Dr. Surya Prakash Vaddi, sir. And Chairman Urolithiasis Dr. Abhay Mahajan, sir. Our distinguished international faculty experts, moderators, and participants, sir. Thank you all for making this webinar very successful. I would like to express my heartfelt gratitude to each one of you for making this academic evening truly impactful. Today's deliberation addressed the evolving role of suction in modern Endourology from internal pressure dynamics to advanced suction techniques in RIRS. So the discussion on the complication profile and the comparative strategies between suction RIRS and suction Mini-PCNL have provided us with a practical insight in the clinical practice. I extend my thanks to all international faculty and national faculty for making this program very successful. My special acknowledged for Dr. Abhay Mahajan sir for his dynamic leadership and to chair the urolithiasis section, and the leadership of USI and ISU for their constant encouragement and support in advancing structured academic programs. We are grateful to our academic partners and supporters for facilitating this educational initiative. Most important, I thank all participants who have joined this evening. Thank you all. Good night. Thank you.
Thank you. Surya Prakash?
Yeah, thank you very much, Dr. Abhay Mahajan, Dr. Vishwajeet, for designing a wonderful program, bringing in all the stalwarts. You have made a wonderful program. The uniqueness is you have made talks by good speakers and expert comments. That is the uniqueness of this program. And to tell all the participants, this program is recorded. It is available in the e-learning platform. I request all of you to log in and see. You can watch the program later on if you missed this because of some prior commitments. All other programs of the ISU are there in the e-learning platform. You can log in and see whenever you're free. And on behalf of ISU, USI, I thank all the speakers, participants for sparing your valuable time attending this program. Thank you very much. Dr. Abhay, you can conclude.
Thank you. So thank you, international faculty and national faculty, for excellent talk and good comments by all the experts. I think we end the seminar here. Thank you very much.
Thank you all. Bye.
Thank you. Thank you one and all. Thank you.
Good night. Thank you. Thank you.
Thank you. Good night.
Bye.